Hello, and welcome to this Clinical Dialogue and eCase Challenge program, maximizing treatment benefits in psoriasis and psoriatic arthritis, how PAs can help improve outcomes. I'm PA Lawrence Herman, adjunct professor in the College of Medicine PA Studies at the University of Texas Medical Branch, Galveston, Texas. Joining us in this discourse are two PA expert clinicians. Dr. Linda Seikhan is founding chair and professor of physician assistant studies, High Point University, High Point, North Carolina. Also joining us is PA Michael Keene. PA Keene holds an adjunct faculty position at the Duke School of Medicine. He is also in private practice at Raleigh Dermatology in Raleigh, North Carolina. My thanks to both of you for your involvement in this important continuing medical education activity. So let's begin. Very basic. Patient presents to a primary care office with a rash. What's the consideration that we need to go through in establishing a diagnosis of psoriasis?
So I think, Larry, it's important to remember that psoriasis is a condition that is clinically diagnosed. There really are no standard testing for the diagnosis of psoriasis. Most folks will present with the classic symptoms of scaly rash, erythematous scaly eruption on the elbows and knees. The scalp, particularly the occipital scalp, is often involved, but not everybody. And psoriasis can occur virtually anywhere in the body. Other places we commonly see it are the hands and the feet, the trunk, and the fingernails as well can be involved with pitting and lysis. So
it's interesting, psoriasis hides as well. So patients can have flares, it can wax and wane, and the places that I will examine a patient if I'm thinking they may have psoriasis is it hides in the umbilicus or the gluteal cleft.
That's exactly right. And even there are other forms of psoriasis, what we even consider inverse forms of psoriasis, which will be in the armpits and the axillary regions. Genitalia is another key place too, so always checking those areas is important.
And I would agree 100%. Clinical assessment is key when it comes to psoriasis. There are no blood tests that can be done that can confirm the diagnosis. And with regard to histopathological assessment, many times that is just not useful. Where it is useful is with a differential diagnosis. So for instance, ruling out perhaps eczema, contact dermatitis, seborrheic dermatitis, as well as other types of skin disorders, onychomycosis.
How do we stage or grade the severity of psoriasis?
You know, one way you can do that is by looking at body surface area. And the way we do that is actually by using the patient's hand. The patient's hand actually equates to about 1% body surface area. So when you look at grading, you look at mild psoriasis as being equivalent to about 3 body surface areas or 3 spans of the hand. Moderate would be 3 to 10, and severe would be greater than 10.
BSA is an important component, absolutely. And then the other side of it is then how does the disease affect function for a patient, their daily living? I'll give you an example. I have a patient in my practice that I can think of that actually had less than 3% of BSA, but he was an electrician and it was affecting his hands predominantly. And so we were able to qualify him as a severe patient under the circumstances and get him the proper treatment with the insurance company. So it is about also how it affects function as well.
So roughly speaking, what percentage of patients fall into mild, moderate to severe?
A quarter of the patients that have psoriasis actually qualifies moderate to severe disease. So it does take asking the right questions though.
So let's shift for a minute and talk about psoriatic arthritis. How do we make that diagnosis?
You really need to think about that as a chronic inflammatory arthritis condition that affects not only the joints but also the skin. So classically, these patients will present, as with any inflammatory arthritis, with morning stiffness and also what we refer to as gelling phenomenon, and that is where there's stiffness after sitting or being sedentary for a period of time. What is a little more specific with psoriatic arthritis would be, for instance, enthesitis, which is pain at the insertion points of the tendons, at the bony insertion points. So think of perhaps plantar fasciitis. And then finally, what we refer to as sausage digits or dactylitis. And when you think of dactylitis, it's not just inflammation of the joints themselves, it's the entire digit. We see that more commonly in the toes than in the hands, but it can occur both places.
Most commonly, we do see skin manifestations with psoriatic arthritis, but that's not necessary, and it may only be, as an example, nail findings and no other skin manifestations.
Absolutely. Most commonly, psoriasis precedes psoriatic arthritis for a number of years or for a long period of time. But you have to think about up to 17% of patients do present with arthritis conditions before the onset of skin manifestations or psoriasis. Of interest is in our practice, for instance, we can see up to 15% of patients that do have psoriasis, but they have never been diagnosed. And that is, as we were talking earlier, your clinical evaluation is critical. When you have a patient that presents with joint manifestations, it is important that you are doing a good skin evaluation, checking the scalp, behind the ears, in the gluteal folds or periumbilical area. I think it's an interesting point that you brought up about nail manifestations, in that very often up to 90% of our patients with psoriatic arthritis do have nail manifestations or nail ridges or some type of psoriatic changes of the nails. And of even more interest is those patients that have nail manifestations tend to correlate with a more severe onset of their disease and progress within their disease, both with psoriasis and with their psoriatic arthritis.
So psoriatic arthritis, I have found to be a diagnosis that is delayed in being made because there's a pretty broad differential and people very frequently consider the other diseases. Let's just briefly talk about the differential diagnosis.
Gouty arthritis is certainly one to consider when someone presents with arthritic pain that might also be a psoriatic arthritis. And then of course rheumatoid arthritis is one we can't forget about as well. Plain film x-rays may be of use in helping to evaluate further what we're seeing, as well as other imaging studies. A rheumatoid factor is an appropriate test to obtain to rule out rheumatoid arthritis. It is usually negative in a psoriatic arthritis patient. So those are some of the things that can be done.
And as we've said, there's no gold standard blood test, but anti-CCP can help point us in a direction?
It can. Now, it can be a little tricky as well because an anti-CCP antibody is also positive in rheumatoid arthritis, but it can be also positive in psoriatic arthritis. Thinking about psoriatic arthritis, I think we have to keep in mind it falls under a broad category of spondyloarthropathies. So HLA-B27 has also been found to be positive in our patients with psoriatic arthritis, which may help differentiate that then from your rheumatoid arthritis.
So we talked about how we grade the severity of psoriasis. How do we grade the severity of psoriatic arthritis?
So that is really focused on the number of joints involved and functional limitations that are imposed due to the burden of the disease.
What are the cut points? How do we define mild, moderate, severe?
There really isn't a standard set when it comes to severity. It really is focused on functional limitations. However, patients may present with oligoarticular disease in which there are less than 3 joints involved versus polyarticular. It also manifests either unilateral versus symmetrical versus axial. It can present in many different ways. So the focus really is on functional limitations, number of joints involved, and that burden of disease.
So let's talk for a minute, Mike, about the role of topical treatments in treating psoriasis as well as phototherapy.
The mainstay, I think, of treatment is the topical corticosteroid therapies there, and there's a host of different options available in terms of steroid topicals. They vary by concentration, they vary by vehicle. Ointments are sometimes preferred. I think foams have become quite popular. The thing we always want to take into account is the surface area involved. How much area we're covering is going to determine what the best vehicle might be, but also strength of the medication. And what part of the body is involved. Certain areas of the body we don't want to put high-potency steroids on for the risks of atrophy and thinning the skin. So there are some other medications available out there. Vitamin D derivative medications, calcipotriene, calcitriol, are very safe and can be efficacious options as well. There's the retinoid medication, topical tazarotene. And lately there has been a combination agent of tazarotene with halbetazole that should be a new tool in our tool chest to be able to address some of these maybe thicker plaques. And then the old mainstays of salicylic acid, anthralin, coal tar tend to be a little messy, a little smelly, but there are agents that are still available as well for treating.
So this is for more mild disease or more localized disease.
Phototherapy is certainly another option. UVB therapies in the form of narrowband as well as broadband therapies are available. UVA also therapies with PUVA, Psoralen and UVA are still available. I don't know how popular it is these days, frankly, but I do think it is out there.
So we talked a little bit about milder to moderate disease. As we move into moderate to severe psoriasis or psoriatic arthritis, we move into a different category of medications. We move first into disease-modifying drugs, and some of these are older, and some of them actually have some pretty significant potential adverse events. But what are some of the drugs that might be used?
Disease-modifying antirheumatic drugs are still popular in many precincts. I think methotrexate in particular is still, in terms of psoriasis at least, used fairly frequently out there because it is inexpensive and it does have a level of efficacy that is reasonable. Other antirheumatic products that are out there too are cyclosporin, acitretin, sulfasalazine. But again, all these drugs have a certain level of toxicity to them that we have to accept. And in this day, there are some other options available that I think are perhaps cleaner in the sense of their side effect profile.
And we have another relatively new category that still falls into non-biologic, and that's a PDE4 inhibitor.
That's one example, is a phosphodiesterase 4 inhibitor, apremilast, and kind of an exciting new drug, an oral medication. It does have its own set of side effects, GI issues, possible association with depression, weight loss, but it is an exciting new drug in terms of how it works and safety, as well as the ease of being able to take it as an oral medication.
Now we have two more categories of drugs that remain in the non-biologic category, and these are for psoriatic arthritis exclusively, each of which comes with potential concerns that we want to watch for as those are prescribed. And I mention this because in primary care, even though I may not be prescribing this drug, I'm certainly seeing this patient and should be aware.
The first is the T-cell co-stimulator modulator, and that is abatacept. It has a very good efficacy profile. Some of the side effects we look at with that are it can increase the risk of infection, particularly to those patients that may have predisposed conditions.
So you can see some relatively minor reactions as well. You can see some upper respiratory tract infections. You can see headaches, nasopharyngitis, and occasionally patients will get nauseous. The other is another new category, a JAKs inhibitor.
Yes, and that is tofacitinib, and that actually has a very similar profile, side effect profile as abatacept.
So before we get into a discussion of the efficacy and safety of some of these biologics, I want to preface it with a comment about the statistics that we're going to be quoting. There may have been occasionally some head-to-head trials within some of these clinical trials, but there were no overarching head-to-head studies. So when we quote statistics in terms of the percentages. They're important for the audience to know the efficacy of the drugs, but it's not a matter of, 2% better than the other drug because they were not compared in that fashion. I just want to pause for a moment because we're going to introduce a term that not 100% of our audience may be familiar with, and that's PASI.
PASI is an acronym for Psoriasis Area Severity Index, and it's a measuring tool to judge progress or improvement. PASI 75, as a matter of example, means 75% clearance with any given therapy. PASI 90s now have become sort of the mantra with a lot of these newer drugs, and frankly that's virtually clear. I know PASI 100 is even banted around a little bit now.
Let's get into some of the agents that our audience may be a little more familiar with, and some of these agents have been out for as long as 20 years, especially for psoriasis. So we're talking about things like anti-tumor necrosis factor alpha inhibitors, commonly called TNF-alphas or TNF-alpha inhibitors. So for psoriasis, we have drugs like infliximab, adalimumab, entanercept, and certolizumab. For psoriatic arthritis only, we have golimumab. I want to mention that the TNF-alphas in particular have one adverse event that primary care should be familiar with. That is for new or worsening heart failure. So that's in patients who de novo may develop heart failure, or people who have had a history of heart failure but are well controlled and now their heart failure worsens. So if you have someone come into your primary care practice or any practice with those symptoms, a quick echocardiogram is certainly warranted to make certain that is not what is happening.
So, as you had mentioned, there are several biological therapies available for the treatment of both psoriasis and psoriatic arthritis. When we are looking specifically at the interleukin antagonists, let's begin looking, for instance, at IL-12 and N23 inhibitors. So, ustekinumab is for both psoriasis or psoriatic arthritis. With regard to psoriasis, there are a couple of trials that we can look at to think about efficacy with this. The first would be a phase 3 Phoenix trial. About 67% of patients treated with ustekinumab versus 1% with placebo actually met that PASI score of 75 at week 12, which is somewhat impressive. Regarding efficacy in psoriatic arthritis, there were actually two trials. The first was a phase 3 Summit 1 trial. These were patients that had failed the disease-modifying agents but were naive to any of the anti-TNF-alpha agents. So in this trial, 42% and 49% of patients treated with ustekinumab at 45 and 90 milligrams respectively versus 22.8% with placebo actually met an ACR20 criteria at week 24. So just a quick overview of an ACR20 criteria. What they actually looked at with that was a composite measure as defined by both improvement of 20% in the number of tender and number of swollen joints and a 20% improvement in 3 out of 5 additional criteria in accordance with the ACR criteria. The other trial was a phase 3 Summit 2, and these were patients that failed either a disease-modifying agent or an anti-TNF-alpha agent. In this trial, it was somewhat similar in that 43.7% and 43.8% of patients treated with ustekinumab, 45 and 90 milligrams respectively versus 20% with a placebo, actually met that ACR20 criteria at week 24. With these medications, your most common adverse effects included nasopharyngitis, upper respiratory tract infection, headache, and fatigue. And then we look at the IL-17 inhibitors, and that is ixekizumab. That is used once again for both psoriasis and psoriatic arthritis. So first of all, looking at the efficacy with psoriasis, we looked at a phase 3 Uncover 1 through 3 trials, in which they found that the PASI 75 at week 12 was significantly greater with ixekizumab versus etanercept or a placebo. In the same trial, they looked at a static physician's global assessment at week 12, Once again, they also saw a significant greater response with ixekizumab versus etanercept or a placebo. And then when you look specifically at psoriatic arthritis and the efficacy for this medication, we looked at a phase 3 SPIRIT P1 trial. In this trial, about 62.1% and 57.9% of patients treated with ixekizumab at 2 weeks and 4 weeks respectively versus at 30% with placebo attained that ACR20 criteria at week 24. Now, the safety profile for this was also quite reasonable with this medication, with the most common side effect being that injection site reaction. And then finally, the other IL-17 inhibitor is secukinumab, which is also used for both psoriasis and psoriatic arthritis. And this was an exciting new front, I think, for the treatment of psoriasis and psoriatic arthritis, because when you looked at the efficacy in psoriasis studies, it was quite impressive. So we refer to phase 3 erasure, fixture, feature, and juncture trials. So this was actually a pooled analysis. The PASI 90 and 100, which we talked about before, is quite impressive at week 52. So in this trial, 62.9% of participants met that PASI 90, or, as we said before, a 90% improvement at week 52, and 37.9 saw a 100% improvement with secukinumab at the 300 milligram dosage. They also looked at 150 milligrams with that medication, in which 30.9% saw a 90% improvement, and 17.5% saw a 100% improvement. With regard to efficacy for psoriatic arthritis, we looked at the phase 3 Future 1 trial. In this trial, 50% and 50% of patients treated with secukinumab at 150 and 75 milligrams respectively versus placebo attained that ACR20 criteria at week 24. And finally, there was a phase 3 trial that was consistent as well, and that is 54% and 51% of patients treated with secukinumab at 300 and 150 milligrams respectively versus placebo for both attained an ACR20 criteria at week 24. With this medication, the most common adverse effects included nasopharyngitis, diarrhea, and upper respiratory tract infection.
And continuing with the interleukin antagonists, there is another IL-17 that's for psoriasis only in this case by the name of brodalumab. And it does have also some trials that are quite impressive behind it. PASI 75 scores and 90 scores were evaluated with a phase 3 Imagine trial. 3 trials, 1, 2, and 3 were pooled as well. The PASI 75 scores were all at week 12 in the mid-80s in the 3 trials respectively. And then the PASI 90 scores and PASI 100 scores, as well as the SPGA of 0 to 1, were significantly superior to ustekinumab when compared. Safety for brodalumab has some unique characteristics to it. It's the standard nasopharyngitis, upper respiratory, headache, and arthralgia that we see with it, but also it does have a black box warning, risk for suicidal ideation and behavior, and thus it does have a registry involved with being able to prescribe it. Another drug that's out there, an interleukin blocker, is guselkumab. It's an IL-23 inhibitor. It's for psoriasis only as well. Phase 3 Voyage 1 and 2 trials were once again pooled together, but in this case they looked at the IGA scores, Investigator Global Assessment, at week 24. And it scored at 83 and 52%, IGA of 0 to 1 and IGA 0 respectively. It was also compared with adalimumab, and that drug was found to have 63% and 30.2% for the 0 to 1 IGA and IGA 0 respectively. So it's an interesting head-to-head was done with this drug, and it's quite impressive. Safety, again, once again, we talk about the same issues with these drugs with upper respiratory tract headache, and injection site reactions are also not horribly uncommon. The final couple drugs we do have here are the interleukin 23 inhibitors, 2 of them. Tilbracizumab is one that's fairly new. It has a phase 3 Resurface trial, 1 and Resurface 2. PASI 75 scores in this drug at week 12 were 66 and 61, with tildrakizumab 200 and 100 respectively, versus 48% with etanercept and 6% with placebo in a head-to-head. Once again, safety considerations are the same with URIs and injection site reactions. Diarrhea is also mentioned with this drug. And finally, risankizumab is a newer IL-23. It was approved this last spring. And phase 3 trials, the Ultima 1 and Ultima 2, were trials run. Co-primary endpoints were PASI 90s in these cases at week 16. The Ultima 1 had a 75% PASI 90 versus 42% with a head-to-head looking at ustekinumab, and 4.9% with placebo. The Ultima 2 had a similar mid-70s PASI 90 with the risankizumab versus 47 with ustekinumab and 2% with placebo. So very similar results in each of the trials. And then SPGA scores of 0 to 1 at week 16 were also evaluated. The Ultima Trial 1 and Ultima Trial 2, both with risankizumab in the mid-80s versus the lower 60s with ustekinumab, and placebos, once again, at the single digits in each case. Yeah, and then finally, the ENHANCE trial with co-primary endpoints, again, of PASI 90 and PGA scores of 0 to 1. The PASI 90 scores at week 16 with risankizumab were 73% versus 2% with placebo. And the SPGA score of 0 to 1 at week 16 was 84% with risankizumab and 7% with placebo. So an impressive set of numbers for this drug. Once again, safety considerations are for mostly URI side effects, and similar to the other IL-23s.
So let's talk a little bit about a patient who's about to be started on one of these agents, and let's talk specifically about biologics. I'm in a primary care setting. So what I try and do before I refer that patient to whether it be rheumatology or dermatology, but I know that likely they're going to go on a biologic, there are certain things that I'll do and get that information back. I'll do a CBC and a CMP. I'll do a quantiferon gold along with that to rule out tuberculosis. I'll look at their hepatitis B status to see if they in fact have ever been exposed, if they're immune, if they've cleared it, because that's going to impact whether they may in fact reactivate that. I'm going to look at their entire vaccination status. So I have to think about things like annual influenza. I have to think about Hep A, Hep B, make sure that if they are not protected, already covered, that they get covered. We have to think about HPV. When we talk about age-appropriate HPV vaccination, ACIP just came out with an expanded range for administration of the HPV vaccine in their most recent guidelines. So if you're not familiar with that, I would recommend that you go to the ACIP website and see that. We have to think about pneumococcus. We even have to think about zoster vaccine, and we have a really efficacious one now that is not a live attenuated, but if it's appropriate. I want to make sure that all of the vaccines that they get moving forward, none of them are live attenuated vaccines, which could potentially put them at risk. I also have to think about monitoring them and continuing to have their vaccine status updated on an annual basis. What should we be monitoring for?
Well, the primary disease that you'll hear about and want to be monitoring for, of course, is the reactivation of tuberculosis. So quantiferon gold is considered the test of choice. And primarily because the PPD, at least theoretically, could be muted in terms of the reaction in the skin because of the biologic on board.
And in terms of monitoring some other things, basic things like liver function tests and renal Is that my responsibility, your responsibility?
I think that's an excellent question, and the reason is, whenever you're treating our patients, in the rheumatology setting or in the dermatology setting, we really look at that as being a team approach. So it really is dependent upon the medication that is chosen. Like for instance, methotrexate, you are going to be monitoring liver functions, you're going to be monitoring CBC. There are certain things that are inherent with the profile of follow-up and such that we need. However, this is a team approach to care with these patients, and these patients are seeing our primary care providers on a very regular basis. So being cognizant of what those results are and ensuring that these patients are following up with this monitoring. We provide them with the scripts to have these things done, and we are hopeful that we are working in conjunction with our colleagues in primary care and in dermatology. That is a critical point.
And basically it's 5 things annually, kind of 5 different buckets: CBC, CMP, LFTs, renal function, and the TB, correct?
Absolutely.
Yes.
I will frequently tell my patients that this is a systemic disease with skin or orthopedic manifestations. What they don't realize frequently, and what perhaps some of our colleagues may not realize, is that the inflammation that occurs with this disease impacts many organ systems. So we have a dramatic increased risk of certain comorbid conditions as a result of the systemic nature of the disease. And cardiovascular is one that is up to 10-fold higher, depending upon what we're talking about within that. Let's just start with cardiovascular disease and what areas we need to treat and certainly monitor, but treat aggressively because of the increased risk.
The associated comorbidities in terms of cardiovascular risk are dyslipidemia, hypertension. These patients tend to be obese many times. We see diabetes and glucose intolerance at a greater rate. Metabolic syndrome is something too that does frequently reveal itself in these patients as well at a higher rate than the general population.
But it's not just cardiovascular. There are other comorbidities. We have CKD, right? Chronic kidney disease, inflammatory bowel, and there is a dramatic link between psoriasis, psoriatic arthritis, and mental health issues, specifically depression in these patients. And I'm not sure if it's a chicken or the egg, but nonetheless, it is definitely there, and it's something I believe that you should do PHQ-9s on everyone annually.
I can speak more specifically to the inflammatory arthritis, which I deal with more exclusively. Any patient that has an inflammatory arthritis, such as psoriatic arthritis, they are at a higher incidence of osteoporosis and fibromyalgia. Anytime there is bone involvement, you're going to increase your incidence of osteoporosis. So you need to begin those screenings with your DEXAs a lot earlier, not only in your women, but in your men. More specific for psoriatic arthritis would be fatty liver disorder. And then you have eye involvement. And so with psoriatic arthritis, as I said earlier, that falls under a broad category of spondyloarthropathies. And autoimmune eye disorders kind of run the gamut across all of those spondyloarthropathies. So that's something you also need to be cognizant of, any type of eye changes in your primary care setting.
So it's an exciting time, lots of new drugs and lots of new treatment modalities that we have in our armamentarium that we have never had before. So it behooves us to be at least familiar, dip our toe in the water, and be able to refer after we make a timely diagnosis, because there are many, many options available to our patients for the first time. So we have had a wonderful, robust discussion here today, and I want to thank you both for that. But if you wanted to leave our audience with one clinical pearl, what would that be?
The one thing that I would like to see people walk away with is the awareness that there is a connection between psoriasis and psoriatic arthritis. And sometimes a patient may present with an inflammatory arthritis, and you have to be aware that you need to begin to look for psoriasis in those patients. The other thing would be early intervention. Once you have damage to a joint, you cannot fix that. And we have a lot of medications available. Early treatment is key.
And Mike, if you'd like to leave our audience with a single clinical pro, what would that be?
Well, I think it's important, especially as a first contact for a psoriasis patient, and many primary care people are just that, to remember the emotional burden of this disease on people. Two things I would make sure that you, if you can do them in your practice as that patient enters your office. And one is to listen. And that sounds simple, but many times I'll, with a new patient, just sit and let them talk. For the first 2 minutes of the visit, just give it to them and let them just talk, and I'll agree and nod and listen and show that I'm paying attention. They'll oftentimes really share a lot of personal information, but also useful things to guiding my thoughts on what might be best for them in terms of therapy. And the second thing I think is then touch them. Many of them come in shamed. They've been told that there's something wrong with them, and people look at them differently. And so I'll, while I'm examining them, touch their arms and touch their elbows, and to show them that they're not. And I think that goes a long way to establishing a connection, as well as I think it increases the chances that they're going to adhere to what you develop for them as a plan. They trust you. So those two things.
I would like to thank both of our expert faculty, Dr. Linda Sekhan and PA Michael Keene, for their great insights and discussion. And I would like to thank you, our audience, for participating in this clinical dialogue. Before leaving, we invite you to participate in the E-Case Challenge, where you'll have the opportunity to apply what you've learned in this clinical dialogue in a real-world clinical situation and receive CME self-assessment credits too. And speaking of CME, to receive your CME credit, be sure to complete the post-test and evaluation by clicking on the post-test button located beneath the slide screen in the video player. The post-test button will direct you to AAPA's Learning Central to complete a post-test, the evaluation, and receive your certificate. I'm Lawrence Herman. On behalf of Dr. Linda Sekhan and PA Michael Keene, we hope you have enjoyed it. Thank you for joining us.